accommodated? Well, somebody else is going to have to fill in. And if the nurse and the physician who have an objection to withholding or withdrawing medically provided nutrition and hydration, if they're accommodated, somebody else is going to have to fill in. So accommodation can have a significant burden on, well, on other healthcare professionals, not to mention administration, not to mention the institution. Now, what about the incompatibility thesis? Well, I think the major problem with the incompatibility thesis is just the reverse of the problem, the major problem with the conscience absolutism. And that is, the incompatibility thesis tends to treat healthcare professionals merely as healthcare professionals and does not give enough weight to the fact that they are also moral agents. And as moral agents, providing a service that is contrary to their very core moral beliefs will damage their moral integrity. Now, you might ask, well, why should we care about protecting the moral integrity of healthcare professionals? And I think there are a number of reasons why it is really important to protect, as far as feasible, healthcare professionals' moral integrity. So for one thing, well, moral integrity can be very important to people. And if they're not able to maintain it, it can be a serious moral harm to them. Secondly, if people do act against their conscience, it can lead to very severe negative feelings of guilt, remorse, and even loss of self-respect. Now, keep in mind, what I'm really talking about here is a situation where people are acting against very important core moral beliefs, not just kind of, tangential beliefs where if you're given a questionnaire, you check this and that and that. These are very central core moral beliefs. Now, this is a little bit of speculation, a little bit of moral psychology, but at least some people have speculated that if a person is required to act against, again, very core moral beliefs, that will have a damaging impact on their whole moral character, so there'll be a decline in a commitment to moral principles. Well, there's an important principle of respect for persons. And respect for persons basically requires that we allow people to pursue their own values. And that would seem to suggest that we should respect people's moral integrity. Now, this one's probably the most controversial. But I think there's something to the idea that having moral integrity, having a commitment to moral principles, is something valuable. There's an election coming up, and I think that kind of highlights how at least a lot of people think that having a commitment to principles is really valuable, as opposed to just doing things to promote one's own self-interest. Now, there are limits to this, I'll grant you. So, people's core moral beliefs can be really rotten to the core. They can be racist, they can be sexist, they can be anti-Semites. That doesn't warrant any respect. My only point is that I think we tend to have some respect for moral integrity that is not just dependent on the actual content of people's moral beliefs, within a certain range. So I would at least suggest that moral integrity is a virtue maybe like courage, where courage is a virtue, but it can also lead people to do very dastardly deeds, right? You think of the 9/11 hijackers. It's really too bad they were courageous. Had they been cowards, and as the plane was heading to the Twin Towers, they said, "Oi, I can't do this," that would have been much better. So in that context, obviously, courage is not a great thing. But generally, courage is a virtue. And I think similarly moral integrity is a virtue. So some other reasons. Well, this is an obvious one. If you believe in the principle of respect for autonomy, then that means that you ought to be trying to allow people to act according to their own lights, according to their own values. Now, this is a concept that may not be familiar to some of you, epistemic modesty. Now, what this means is simply, look, sometimes we're mistaken. Now, it's not just about ethics. We're mistaken about factual matters. So we're not perfect. So this is not moral relativism. It's not like there is no right and wrong. Yeah, there's right and wrong, but sometimes we don't get it right, what's right and wrong. And so epistemic modesty, if you have that view, then you say, well, gee, maybe I should give people some moral space because for all I know, I might be mistaken on this belief. And they might be right. Moral progress. Well, moral progress means sometimes people who today are outliers, they're refusing to provide certain services that they think are morally wrong. They might be the harbingers of moral progress because it might turn out and 20 years later we see, oh yeah, they were right. Now, the one instance I can think of that kind of fits this description is the practice, I guess in the 50s, maybe the 60s, where it was thought to be acceptable to not perform surgery on newborns with Down syndrome if they had duodenal atresia. It was thought not to be wrong to just let them die. And there were some physicians at the time who said, no, that's wrong. And it turns out today that that view is now the accepted view. It is thought that it is not acceptable morally to allow Down syndrome infants to die. Well, some practices continue to be controversial, like donation after cardiac death and palliative sedation to unconsciousness. If you believe in toleration, moral and cultural diversity, seems like accommodation is the right thing to do. What about diversity in the healthcare professions? Just think if we didn't try to accommodate people with disparate beliefs, and we followed the New York Times and Julian Savulescu, the healthcare professions would be very, very monochromatic. There would not be very much diversity, because all that diversity, they'd be in philosophy. And then finally, it might very well, if again, a lack of accommodation, if it really does get a lot of people to go into philosophy rather than medicine or nursing or pharmacy, then that means basically you're giving a disincentive to people that have a moral conscience to go into healthcare professions. Okay, so having now made a case for why both of these extremes are not acceptable, what I want to do is recommend an alternative. And I think this is an alternative that is, in fact, justifiable, and we can talk about it. So the general aim, I think, is pretty straightforward. And that is, well, to accommodate health professionals who have conscience-based objections, but to do so without having an excessive burden on patients or other healthcare professionals or institutions, et cetera. In other words, to do so without burdening other interests and values excessively. Now, I don't think anybody could object to that. That sounds great. The problem is the devil's in the details. And I don't have really specific details, but what I do at least have to recommend are some general guidelines. And what I'd like to do is kind of take these guidelines and think about some of those cases. So the first guideline has to do with, well, insofar as it is possible healthcare professionals who anticipate having a conscience-based objection to providing some service that routinely people in their field are asked to provide, they ought to notify, if it's in an institutional setting, they ought to notify the supervisor, the head of medicine. If it's in a private practice, notify patients, notify other people in the practice. Now, I think this is very easy to do in the first two cases, right? So the emergency room physician. Rather than waiting till the patient comes in, right? EMS is taking the patient into the ED, and at that point, the physician's saying, well, you know, I really can't tell this patient about EC. I can't provide EC. Rather than waiting till that moment, the physician should have informed the head of emergency medicine, there are situations in which I can't provide services. Specifically, I am opposed morally to emergency contraception. Now, why is that a good thing? Well, first of all, I think it prevents these kind of horrible situations one-on-one. And secondly, I think it makes it more likely that the physician can be accommodated. Now, case 3 I think presents somewhat of a problem here because it's not an in-principle objection, right? It's a lot easier, I think, advance notification. If you know, oh, I can't provide this service, and then you can notify people. But the third case, remember, they're not opposed to withholding treatment from newborns. It's just in this particular case, I'm sorry, to provide it. They're not, they provide medical care to compromised newborns. But it's just in this particular case, they're opposed to it. So you say, well, how can advance notification work in this case? And my answer to that is, well, they should at least think about situations in which they are going to be compromised if they're asked to continue caring for newborns, for neonates. And they can then inform the supervisors about that, right? So it's not their, but people should be able to at least think about these situations in advance and say, well, these kinds of cases I'm going to have trouble with. Okay. By the way, perfect time now. If you have any comments or questions, feel free. If not, I'll just move on, okay? Well, let's go to, but seriously, any questions or comments you have about applying these guidelines? So the second one is a guideline that says that, well, accommodation shouldn't impede, whether it's a patient or a surrogate, shouldn't impede their access to, or timely access to information, counseling, and referral. Now, some people who write about conscientious objection have a more stringent requirement or guideline here, and that is that the provider herself should provide the information or should provide the referral. I'm sort of more willing to say, well, look, if the information can be given to the patient, if the patient or the surrogate can receive that information in a timely fashion, then it doesn't matter who presents it. Right? So take the emergency room physician again. Well, if it's possible, if it's feasible, without any undue burden on the institution or the emergency department or other physicians in the emergency department, if it's feasible to have an arrangement where when patients come in, like this situation, there's always someone else available to provide the information, then it's okay. But what does this mean? Well, I think what it means very clearly is accommodation or the feasibility of accommodation is going to be context dependent. So if it's a large emergency department in, let's say, UPMC Presbyterian, I don't know how large your emergency department is, probably pretty large. Okay, so if it's a fairly large emergency department where there's always at least more than 2 people on call, or at least 2 people on call, and only one has an objection, then it might work. But if it's a very small emergency department in a small community hospital, then maybe accommodation will not be feasible, will not work. Okay, and that's an implication of this particular guideline. Now, the next guideline is basically the same thing that now refers to not just the information, but the access to, timely access to the service. So going back to case 1, well, the accommodation cannot interfere with that patient's timely access to emergency contraception. And again, that's going to be context dependent. In some emergency departments, there's going to be enough staff available where that can be done without excessively burdening anybody. But in other emergency departments, that's not going to be feasible. Okay? And then the last is just now refers to, well, the burdens on other healthcare professionals and the institution and the department. And again, that means this is going to be very context dependent. So in some places, it's going to be possible to accommodate within these guidelines, and in some places, it's not going to be possible to accommodate within these guidelines. Okay, so philosophers love to give an objection to themselves and then to beat it away and impress you with their brilliance. So I think here is the major objection to my approach. And in the discussion period, which I hope is going to follow, you can point out other problems and other objections. But I think the principal objection is that this, what I call reasonable accommodation, is limited, right? It's limited by the impact on other people.